Please welcome our next panel of the day, Innovative Approaches, featuring Gary Blake, Jess Dalton, and moderated by Scott Rifkin.
Thank you for being here. Can you guys see? I assume you can hear me in the back because I don't think I even need a microphone usually. So thank you all for being here. Let me do some quick introductions. I am thrilled, I'm just thrilled to have Gary Blake on my left. Gary is the owner of Creative Solutions in Healthcare with 150-ish facilities in Texas. I've had the pleasure of working with Gary in an iSNP organization for the last, 4 years? 5 years? 2 years? 2 years? 2.5 years? Yeah. Okay. 2 years. And it's going very well down there. And so I'm thrilled to have Gary on the panel, and he'll give his opinions on this topic. And then Jess Dalton to my right with Ensign, Vice President of Strategic Alignment and Innovation. And again, we've had the chance to have a nice conversation, has really creative ideas and thoughts on where we should be going. Let me give you a little quick background, and I think most of you know bits and parts, or maybe most of this. We're heading for value-based care. And the question is, well, what is value-based care? It comes down to this. It comes down to rearranging our incentives in our industry. You know, our incentives in our industry have been interesting and sometimes counterproductive. How long somebody can be in the facility, the various incentives we have today. But the new incentives that the government is promoting, and we'll talk about the timetable in a second, are all about outcome. It's all about how do you keep people healthier, happier, and out of the hospital. From an industry perspective, from a PR perspective, for the industry, it is a better group of incentives. But the real issue is, whether we like it or not, it's coming. It is going to change how we run our facilities. My background, I know a lot of you, but my background is I'm an internal medicine doc. I spent a number of years helping the health department in Maryland turn around troubled facilities. Then I owned 23 facilities and about 4,000 beds. And then I went on to start a company called Real Time Medical that does data mining for value-based care in about over 2,000 facilities now. And we also own a bunch of iSNPs and a REACH program, which is another program we can talk about today. But it's clearly coming. The government has made it very clear by the year 2030 that they want every patient in every nursing home in a value-based care program of some sort. This morning, if anybody's got their healthcare news bulletin, the government announced, CMS announced that they're going to start a program where they're going to take 10 states and put the hospitals on budgets. It's modeled after the Maryland program. Maryland has been the only state in the country where hospitals don't get paid fee for service. They have a budget. And every insurer is required to pay into the budget. But a hospital gets the same amount of dollars whether they admit 10 patients or 1,000 patients. Think about that for a second. So now their incentive is not to admit people, it's to figure out how to keep people in the community healthy and out of the hospital, and they make more money. So just this morning, they announced that 10 states are going to go to that. Those 10 states, the hospitals in them, are going to change the way they interact with nursing homes. It's all part of this value-based care move. They're now going to be looking at their nursing homes more aggressively than ever of how do you keep people in your facility and out of our hospital? Because they're going to be on budgets. They don't want you to admit folks in those 10 states. So you may want to look for that in your news feed somewhere. But I think the greater point is that's where we're heading, okay? Now, let me turn this over to Gary Blake for a moment and ask Gary to talk a little bit about where Creative Solutions is, how they're looking at value-based care, and where we go from here. And then I've got a bunch of questions for the members of the panel. And then at the end, I think we have 45 minutes. And there's a timer going, you guys can't see this, but it counts backwards. I think we launch at exactly 0. But let me ask Gary if he would to talk a few minutes about where Creative Solutions is in their thought process around value-based care. And then I'll ask Jess to do the same, and then we'll go to a list of questions I have. And then at the end, we'll take questions from the audience. So Gary.
Sure, thank you very much. Good morning, soon to be afternoon to you all. So value-based care for us is also a cultural thing. We have always been dependent, when Melissa and I started the company in 2000, on customer service, keeping that patient happy, whether it be through activity programming, social services, nursing, interventions, certainly rehab where needed, and then medication interventions. So it's part of our makeup as a company, and then also being in a low reimbursed state such as Texas, and then all of our eggs are in one basket in the state. So we have a unique opportunity to have always done more with less. And the other side of this, having iSNP partner, having the right culture within the company that is very forward-thinking from a technology standpoint, with our partners, certainly with real-time, Tapestry, and Data IQ, we're able to leverage technology to really enhance our operations model so we are getting the outcomes that we expect, and in some markets actually improving that by keeping the resident in our facility and then having a higher quality of life. Because when we drill down, no one wants to go in and out of the hospital, because then we look back on that patient's care and it's, oh, you're dealing with the weight loss from the hospital, you're dealing with the skin integrity issues. So being able to have a higher trained nurse, higher concentration of physicians and nurse practitioners makes perfect sense for us. As a company, we're excited about value-based care and where it's going to take us, and we'll certainly be ready.
Thank you, Gary. Jess, your thoughts?
Yeah, from the lens of, a multi-state organization that seems to be pretty big, and yet we operate at an individual facility level, and everything that we do and deliver is local. It's so true to our organizational structure and to our culture, as Gary mentioned. It's so important to have that engagement locally. I'll tell you, maybe it would be a bit disingenuous if I were to say that we're not somewhat frustrated by value-based care. Because of the rapid nature of programmatic release, announcements from CMS and CMMI, I mean, this is a group that means business. I think we all know that. I looked back over some of my notes just in the last 20 days, and there have been 4 value-based care models, programs, or initiatives newly announced that can and will impact skilled nursing, that some of which we can be direct participants in, and some of which we will need to find creative ways to participate with others in. But, and in addition to the 4 brand new models or programs, there are updates to existing or pre-existing models that have also occurred in this last just 25 days. And the rapid nature of this move and this push into value-based care is stressing and it's taxing. We have an iterative model, and we achieve great best practice adoption and implementation through kind of a grassroots methodology. And sometimes that helps us. For the most part, it helps us. Sometimes it's challenging to operationalize exactly what's being asked of us in these value-based programs. And so at the bedside implementation, and from a technology and a platform perspective, and from a continuity of care, we really find ourselves in this kind of the crosshairs of balancing, large population health strategies and solutions with individualized patient care. And I think that crossroads is the crux of value-based care for us. It is in itself the definition. We have to, as an organization and as an industry, become really good at driving large-scale population-based management and efficient and quality and efficiency outcomes without losing sight of that individualized care that is so critical and important in our local communities. So value-based care is very exciting to us. We believe, just from a cultural standpoint, that we should be first adopters, that we should be kind of that tip of the spear of innovation, so to speak. And that's hard work in and of itself, just to stay on top of all of the newness and the changes and the opportunities that are being extended to us as an industry. But we're excited about it, and we have a track record of success within certain value-based models. And I'm excited to just maybe share some perspectives today on those key points. So it's good to be here.
So Jess, let me ask you a question.
Yeah.
Take 3 years, take 10 years. So that's halfway to when the mandate occurs at the end of the decade, and then 3 years after that. Where are we with value-based care? Where's your organization with value-based care 3 years and 10 years from now, when you look at the impact on finances, the impact on regulatory compliance, the impact on outcomes and patient satisfaction?
Yeah. I think that there's a lot of investment that needs to be made in the short term in order to be successful in the long term. And that investment is hard to capture and hard to pin down because we have so many technological advancements and so much innovation happening in the healthcare AI space. We were talking just beforehand where there's this other intersection of value-based care and artificial intelligence, and it's being coined as scalable precision medicine. Right? Where does skilled nursing fall within this framework of scalable precision medicine? How are we, and we're asking ourselves this question in the short term, how are we as an organization investing our capital wisely and not for flash in the pan, innovative, short-term impact, but how are we investing our capital in such a way that it will increase not only our value proposition as an organization, but also our delivery of outcomes that align with value-based care, the aims of value-based care. We've already been very much involved in BPC. I'm sure most of you have or were in some way. As a self-convening organization, we had a successful run, and we approached that from a learning lens. We're involved in ISNP, and we're doing so probably at a slower pace than a lot of you because we're modeling it out for ourselves. We're really trying to understand and re-engineer even an ISNP delivery a care model that's an amazing model of care. We're trying to engineer it differently so that it really translates to our localized delivery of care model. We're very much involved in the alignment process and in the contracting space with other value-based models. REACH ACOs are a real focus for us, as I'm sure they are you. But we're also investing in our structure and the infrastructure of our organization such that we're able to actively participate as risk-bearing entities and as a risk-bearing organization in some of these models that seem to be exclusionary to skilled nursing providers. And we know them. BPCI and its further iterations excluded skilled nursing. And yet there's so much promise. MSSP ACO, hot on the press right now are all of the 2022 results. And we're seeing, on average, every MSSP ACO saved $1.8 million on average, but there were some that saved up to $31.7 million or $25 million. And it's been said from CMMI that is the permanent standard from which CMS is going to build. Now we have this bridge to REACH ACO. And also with some of these new models that I've just mentioned, one in particular, the GUIDE model of care, which is dementia specific, right? In order for us to truly actively and directly participate, we need to be a Medicare B beneficiary and payer source and standalone entity in order to not just be a participant or an aligned participant or participant partner, I guess is the word that's being used, but to actually be at the table in carrying out the work. So there's a lot to be done.
So Jess, is it fair to say that your organization 10 years from now would ideally be at risk for all the patients and have programs where you can share in the savings by keeping people healthier?
I mean, I think as an organization, the answer is yes. I also think that as an industry, the answer is yes, right? The timeline for 100% of beneficiaries to be engaged in a value-based payment model, an alternative payment model structure, I can't recall off the top of my head, but it's soon. It's like within the next 3 years, right? 100% of beneficiaries to be tied into a value-based model. If we don't see ourselves as an organization in that same space and behaving financially in that same way, we'll be obsolete. We'll be a commodity in a sector that cannot exist and cannot survive as a commodity. Right? We have to own lives, and we have to be at the table, at the risk-bearing table.
Thank you, Jess. Gary, sort of the same question. Where do you think that creative solutions will be 3 years from now and 10 years from now with these concepts of value-based care?
You know, that is a question that will keep you up at night, right? I think within a 3-year timeline, I think what you see is certainly working your efficiencies from your various vendors, understanding that you are going to need to grow your company, you're going to need to help your vendors grow, and I think understanding the assignment from the very tops of your C-suite all the way down to your line staff, I think is paramount. It creates from a 3-year to a 10-year scenario. I think our recruiting will completely change. I think that recruiting has to change, and I'm gonna tell you exactly what I think the pain points are. For years, we've been able to, back and forth, Jess, we've been able to go and hire, recruit, and retain experience. People with 10, 15, and 20 years of experience. That's not necessarily what we're going to be looking for. We're going to be looking for that RN that is aggressive, innovative, quick to adopt new technologies, quick to pivot. And I know that word is overused, but it is a very appropriate word. And all along, understanding the assignment of how we change the concept of what long-term care looks like in our space and in our communities, and becoming the leader in those communities is what it's going to take. You know, certain high dense markets, you know, you're one of 200 skilled nursing facilities, but you really are going to have to be in that top 10% in order to really thrive. So I think that's where we see it. I know there's more education to come. There has to be that. But I will touch back on the way our benefits packages, that's kind of where I want to end up. I think our benefits packages are going to drive even greater desires and needs of the worker to keep them in place. And Melissa and I struggle in changing our benefits package quick enough because you almost need a cafeteria style plan. I know I'm straying from this, but I promise it'll make sense. While the care will be completely different for the resident, I think the way we care for our employees is going to drive the outcome that we get from that resident. And we're up for the challenge.
So let me drill down on that point you just made. Are you talking about changing the way you incentivize in their employment packages the folks that are responsible to make these programs work? Where you start to put admission numbers and readmission numbers and outcomes into that package in a more aggressive way?
Yes, and we've already begun that. Basically, all of our incentive programs in the next 18 months will be burned down and built back. We actually have to do that, and we should do that. And I've been in the business 30 years. Listen, I've been in the business 30 years. I have to put a new lens on. I'm going to borrow Jess's word. We have to have a new lens on this. And I have to be influenced by people who understand what their departments need to look like. I need to know what nursing needs to look like, recruiting, HR. I need to know exactly what the rehab world looks like and how we enhance it and use it appropriately. So all of those things are going to in the next 10 years, while we don't have really 10 years, I mean, that the icing has to be on the cake and it has to be delivering results for us. And I think we do that now, and I'll wrap this up. I think we do that now by being very attentive, and I've only spoken about being responsible to vendors and to our employees. We have a huge responsibility to our banks and our lending partners, as well as our landlords, our REITs, and our private family offices that Melissa and I have been very fortunate in that we play in all those markets, we play in all those arenas. But we have to keep reinvesting in our properties. We have to keep putting new bows on the package, not only on our clinical product, but our physical plants as well.
It's interesting you say that about your lenders. We've actually been approached in our data mining business by lenders, by REITs, to plug in the information so they can see how their facilities are doing on admissions and on readmissions and on outcomes and all of that. So it's interesting you say that, and it really will be a partnership along those lines.
Well, I will say this. I think building for your banking partners, access portal, and we're doing this already, to where the banks can see individual facility financials, consolidated financials. They can see trends. This also goes down to a lot of our family private offices, a lot of our REITs. They do have access to our portals, and they can see trends. And I think that's important that they see your business not from a 45-day lens or a 90-day lens, but whenever they want to see it, whatever their reach is, if a board member says, hey, what's going on in this market? I saw a blip on the news. We need them to have access. Well, boy, our Texas buildings with creative are in great shape, or there's, 3 out of 10 are struggling with this. That's the kind of transparency we'll use to grow our business. And that's just the same transparency in retrospect that our insurance companies are going to need to see.
Very good. So Jess, talk a little bit about what Ensign is doing to operationalize the change in the way we're going to provide care. And just to coordinate a little bit with Gary just said, if I'm an investor or a bank or a REIT or a family office, there's probably no better parameter to look at than admission rates. I mean, finances, of course, but if you want to look at the quality of care, the admission rates are going to tell you, to the hospital, not admission rates to the facility, are going to give them a pretty good picture on how the facility's doing with outcomes and even your regulatory risk. Yeah. So maybe talk a little bit about the operational side of all of this.
I'm lucky in my role. It makes me a little bit schizophrenic because I travel quite extensively. And I do so intentionally because it's so easy for us to become distanced from our operators, from the actual work that's involved in value-based care. And I have the privilege to be able to be in our buildings and with our operators daily in different states. And I'll say this, one of the biggest challenges, it does no good for me to know everything that there is or everything that I can possibly know about value-based care in an organization that's locally driven and that, embeds ownership at the community level, right? Every one of our operators and even every one of our bedside care delivery team members needs to understand value-based care. I would say that's one of the biggest challenges that we are tackling and that we're confronting as an organization is the educational elements that go into every layer of care delivery within our organization, right? We want our CNAs and our nurses at the bedside and our respiratory therapists and our physical and occupational speech therapy. We want everyone to be able to speak the language of value-based care. And the only way, really, that they'll be able to speak it is by living it and doing it. And so that is the impetus and the urgency we feel, right? We see ourselves as a leadership development company that happens to be involved in healthcare, okay? And we have to build leaders. We have to invest in our people in such a way that they will be able to be effective in managing the cascade of acuity that we've already been feeling, but also in delivering successful outcomes in this cascade of value-based care and risk sharing. And I think that's one of the biggest elements of operationalization is that boots on the ground educational focus so that we're all speaking the language of value-based care. And then that helps us to develop this culture of value-based care and outcomes-based metrics and monitoring, right? And it does change and influence incentives. It changes the way that we see how we measure ourselves and how we deem whether or not we're successful, right? If we're just busy doing, that can be a value decoy. And we don't want to be a value decoy organization. We want to have actually, tangible results at the end of the day that are sellable to investors, sellable to individual partners, REITs and others that we're involved with, that really convey the value of what we're doing and the value that they can access through our work. And we want to be able to convey and sell our outcomes in the same manner that Medicare Advantage organizations have done, right? And they've done such a great job at doing so. We really, that's the precursor, right, to all of this. And so one other element that we've been doing is we've been getting really good at managed care and case management and patient transitions, right? If we're not really well aligned with our managed care organizations and learning from how you might have various opinions of them. I know some of our operators do or don't, right? Some good, some bad, some annoyed by or what have you. If our operators can get really good at aligning and delivering in the managed care space, we're very well poised for value-based care.
So thank you.
Yeah.
Years ago, not years ago, but a number, 10 years ago, when I had 20-some facilities, we didn't like that our readmission numbers were 23% in that range. And we made it a focus. And there's been a lot of studies done. I mean, a number of academic studies that between 50 and 70% of the admissions from nursing facilities to the hospital are preventable. They're preventable with, the iSNPs do it using nurse practitioners that see the patients frequently. REACH programs are doing it with the data mining, those sorts of things. They're very preventable. We made that a focus of the company, and I want to hear more from both of you on your thoughts of this. We made it clear to our people that those numbers mattered, whether you're the administrator, the DON, the charge nurse, the quality assurance nurse, they mattered. And we got that number down to 8.5% across the company because our teams tend to focus on what they think we focus on or they hear that we focus on. So talk a little bit about how you focus your teams on very specific measurables to get to because at the end of the day, you got to have something to measure to see how your folks are doing.
Yeah. We use data, and not just data for data's sake, but we really try to put the right data in front of the right people at the right time. There's oftentimes, just because of the lag of a 30-day readmission metric and measure, a level of comfort or maybe an ease at reporting out in that same lag type function or fashion. And we just simply don't find value in those lag measures or metrics. And so we've developed a data analytics platform that everybody has access to where they can see every day the value that they've lost through hospital transfers every day in real time, right? And then we have a prompt to help them perform and incorporate into their QI and QA if it is a challenge and a problem for them in their buildings on a weekly basis. We combine lead and lag measures to drive the real-time efforts and to kind of put a focus on where a facility could improve. We also monetize every loss, right? Any day that a head is not in a bed, that's a lost opportunity revenue calculation due to a readmission that probably was preventable. And so we do those calculations as well. Our EDs speak monetization. Our clinicians speak care and quality. And so we don't just do a one-size-fits-all data push. We actually provide and give them access to their own data in a very transparent manner, such that clinicians can see and measure by per thousand patient days. They do so already with falls and with infections and with the other CMS quality measures. So our hospitalization metrics are also in that translatable clinical language. And we speak dollars and cents within our EDs, and then we try to grow our DONs, our directors of nursing, into EDs themselves, right? And so there are just a few things that we do, but I think the right data, speaking the language of the discipline at the right time is critical. And it cannot be lag data. It has to be real time. We have to be measuring what we're doing now to know where we're headed in the future.
Yeah, the national numbers, and again, if I'm wrong on these, please correct me, but the readmission numbers, which is your short-term population, has been in the 22, 23, 20% range, wherever it's been. The goal number for all of us needs to be 8 or 9 or 10%, and it's very doable. On long-term care patients, the national average has been about 3,000, 3,200 hospital days per 1,000 patients per year. That number needs to be down around 1,200 to 1,400. And as Jess said, that's very doable. So Gary, let me turn this to you, and maybe when we mention a little bit, and I know you're focused on keeping people out of the hospital as well. Talk a little bit about that focus.
Sure. So for us and how we use data to kind of pick up, Jess, where you ended, it has to be actionable. You have to be able to see the data and know what to do with it, or have access to people that can give you clear, concise direction. So that's one of the key things for our organization. And then making sure that everyone is in alignment, and from that aspect, how our mornings start and how our afternoons end is key. And some facilities call it a stand up and then a stand down. I don't care what you call it. It's basic, simple communication 101, and it shouldn't be a novel concept in our industry. But it seems to be one of the largest stumbling blocks that we have, and I think because poor communication is tolerated in so many other companies, I think when you raise the bar, you tend to, those employees self-identify that aren't going to comply. So while that's a benefit, and then as far as continuing to drive from an operational standpoint, I think look at wasted footsteps in all aspects. If you are having to repeat yourself to key staff, they are no longer key staff and should be promoted to the industry or promoted out of your organization. I think that is another area where we tend not to thrive in long-term care is, well, that position's filled and you check that box off. But if we're going to get to the 10-year through the 3-year interval or however you get there, communication is going to be key. Like I said, reducing footsteps, reducing keystroke, and reducing the touch points to get your message across, because every saved footstep is more time with that patient, more time to assess what the patient really needs. And it may be, and I'll even drill it down to attention seeking. Some of those residents love to be frequent flyers to the hospital because they are the center of that ER's attention and that acute care's attention. So being able to head that off, I think, is key for all of us. And it continues to drive the customer service piece as well.
Very good. Let me talk a little bit about data itself for a minute. It's nice to know that your readmission number in a nursing home is 16% or 12% or 20%. But you can get deeper in that data, and the software package is part of what we did when we built our package, was build this into it. I want to know what day of the week the admissions are occurring. I want to know what unit. I want to know which nurse. I want to know which doctor. I want to know which diagnoses. Because you can very simply, with today's basic data mining tools, know that our problem is on Friday afternoons when Dr. Smith is covering. Because when they call Dr. Smith, who's covering for the regular doctor, he don't want to deal with it. He just said, well, send him to the emergency room. Those are really preventable admissions. I mean, tremendous. And you send an 85-year-old to the hospital, guess what happens? They get admitted. Whether they could have been taken care of very easily in the nursing home or not, they get admitted. So to be able to drill down on that data in your nursing home, capability exists today. But you got to put it in place, and you got to have somebody who looks at it. But it's not hard to put in place, and it's very simple to see. So let's talk about roadblocks for a minute, because let's go about 3-4 more minutes, talk about roadblocks, and then we'll take questions. We know that CMS has this mandate. CMS is not always concerned with our problems. In fact, they're usually not concerned with our problems. And so the question is, what are the roadblocks? Is it staffing? Is it leadership? What are the roadblocks that are going to get in our way to making value? It's going to happen. So the question is, what gets in the way for success in this area? So Gary, maybe you would start that.
Sure. So our roadblocks, our obstacles are certainly uneducated physicians, hospital CEOs, directors of nurses, administrators, and I don't think I know this. I've been doing it a minute like a lot of you guys. Having an administrator that says, oh, that's nursing, they call those shots. Or nursing that says, oh, that's administration, they call those shots. Those days need to come to a complete and utter halt, because they are the biggest interruption, diversion in the way we care for our residents. People need to know they can correct a problem on the spot and then work with those doctors. And I think, Scott, what you hit on about we want to know what unit, what day, what shift, what nurse is sending those patients out, what nurse is not assessing, and fine-tune that, as well as making sure that if you have a customer service reporting program, you spend a little more time on it, because those things are like encyclopedias. They give you insight into what's really making that family tick, what's making the complaint, what it is, and how to head it off, and training your people and your staff how to keep those issues from arising again. But it all goes down to actionable items that they get to own, and we all have to own what's going on in our facility, what's going on from a clinical aspect, and make the appropriate, timely interventions.
Very good. Thank you, Gary. Jess, your thoughts on that? Where are the roadblocks?
Sometimes we get in our own way. I think we've been in the industry, we've done the work for so many years, it's hard to change. It's really hard to embrace change. It's hard to do the structural changes that are needed within organizations that are long-standing to accomplish or accommodate the changes as well. I think one of the other barriers that we face, in addition to what you mentioned, and I agree with you on those points for sure, is, the disparate and fragmented information systems, right? That we're trying to connect the dots across a continuum of care and multiple levels of care. And that fragmented, and we've been probably as a sector and industry, airing this concern often, but our ability to become navigators of patients, transitionalists of patients, accomplishing the aims of population health, but not losing sight of that individualized care component. That's a very tricky proposition. And I think that we're also somewhat tried by the fact that we do have and care for a short-term skilled patient population, and we also care for a long-term care population. And the incentives and the payment incentives for those two populations are very different. To the point at which, yes, under ISNP, we want to keep a long-term care resident in-house. We don't want them to go to the hospital. But on the other hand, if they go to the hospital, they come back and we can skill them, right? And it's an interesting misalignment of incentives. It'll be really interesting to see what happens with the model, right, Scott, that you mentioned, this AHEAD model, which is what it's called. And these states that will be implementing this proposed you know, I guess, new payment model, much like Maryland has, right? And it'll be interesting to see how that impacts us as a skilled nursing industry. But I think one of the other barriers that we have is quite honestly having a seat at the table. I don't think that we're there yet. I don't see CMS and CMMI developing programs specifically to our area of expertise. Maybe this dementia care model will become that, right? We are and should be seen as the experts in dementia care. But there also is an LOI timeframe, and we have to submit our letters of intent by September 15th, and we have known about it for about 5 days, right? And so that's what I mean by we can sometimes get in our own way. I feel like we should be, everyone submitting letters of intent. We should be, as a sector, putting our foot forward and saying, hey, we want formally to be involved in these programs. Letters of intent, you can always do the research and get the additional data from CMS and decide later whether you want to do it or not. But I don't think CMS is hearing from us enough, right? We're not putting our foot formally into these programs in a way that I think we could as a sector. And so that's what I mean by getting in our own way. We want to be very much at the table, owning risk and doing these value-based care models and owning them. And yet, I don't know how well we do at indicating that formally to CMS. Our associations do an amazing job, but I think that we can also do more as operators from our perspective. So probably additional barriers, but for time's sake, yeah.
Sounds great. Okay, so we've got about 4 minutes left or 5 minutes left or longer if you guys can tolerate us. But why don't we take some questions, concerns, disagreements? I see a question. I'm holding my eyes up here because mostly we've been blinded by these lights looking out at everybody.
There you are.
But there's a gentleman right here.
Well, you're probably glad, Scott, that you're blinded right now. It's Jason. It's Jason Furman from
Hey, Jason, how are you?
Hey, Jess. Gary, nice to meet you. So the question I have, CMS.
Jason, you've been a pioneer in this.
You've got.
By the way,
the industry has no seat at the table with CMS and CMMI. There's zero, which is grossly unfortunate. The question I have is, how do you balance value-based care and the nexus with your real estate obligations? So you're a combination of both a healthcare delivery company and a real estate company. And the true fact of the matter is, the better you take care of people, which is fantastic, you see your income go down because your bet is that you're going to see an increase in your referral stream. But if you don't see that, then the fact that somebody doesn't go to the hospital, doesn't come back with a Part A stay, then they're right back Medicaid. So instead of getting paid $250 a day, you get paid $600. So, or the opposite. So where do you see the nexus? Because it really is, and Jess, I think you hit on it, it really is a challenge within the industry. And value-based care is extremely important. I think you even referenced the fact that you don't want to be commoditized. You have been commoditized. ACOs, that's how they make their money, whether it's ACOs or ACO REACH. ISNP is a close thing to something that's aligned with this population. But how do you see this all kind of coming together so financially it ends up paying for itself?
Jess, you want to take that one?
I mean, I think that we've done a couple of things in-house that have helped us with that challenge. We did create a captive REIT within our organization so that we can do exactly what you're talking about, right? Really leverage the value of the care we're delivering and also access the value of the real estate that we own and pair those together under a captive REIT scenario such that our investors and owners, and that's a very real, right, play to that end, right? That's kind of hitting that crossroads internally, right? And not that we aren't and don't work with other REITs, we certainly do and we want to, right? But that's a necessary element that we found to be preparatory. right, for us as an organization.
You're an anomaly in that you do own your own REIT.
Yes, and the way that we've even set up the captive REIT is kind of an anomaly, and Wall Street kind of looks at us like we have 17 heads. But it's okay. Like, we're okay doing something different, right? And so I think that kind of lends itself to being creative, right? And kind of being out of the box thinkers and looking at this future state. And by the way, it's 2030 that 100% of beneficiaries will be involved in a value-based payments model. But that is necessary, right?
And the other thing I would argue, and I agree with what you just said, is the closer we can get to the dollars, the better. And I think, Jason, you'd agree with this. You know, if you dropped admissions to the hospital from nursing homes by 50%, and the studies show that that you could do this. If you can get down 50%, and the typical iSNP is doing it, and other programs are doing it, the savings is $14 billion a year for the federal government, $14 billion. So the closer we can get to that $14 billion, the less the scenario that you mentioned, where if you keep people out of the hospital, we don't necessarily make money. If you can get close to that $14 billion and be the entity and have your own programs and not be contracting through somebody else, then there's the likelihood you'll actually make more dollars, because you're now earning a piece of the savings from the hospital side, not just from the nursing home side. And that's always made a lot of sense to me. Gary, you got thoughts on that?
Yeah, so I think, and I certainly understand the question. I also think how we maximize all the other programs that we're participating in, such as different QUIP programs, to make sure that you are hitting all those metrics, that you are not leaving 50% of those QUIP dollars on the table because, oh, yeah, that nurse, the RN hours, or whatever the components for your state are. I think that's key. And I think educating your people about how important it is and what the long-term benefit is. There is that transition. There's the learning curve and there's the revenue curve, and both can be extremely painful. Making sure that your banking partners, your investors understand how that transition is going to look. And let me tell you, I love to keep things simple. I believe in you state the problem to whoever you're speaking to. You state the problem, you tell them what you are going to do with timelines, short timelines. And then the third component is you tell them what to expect. This is where we are, this is what we're going to do. We've already started, but by golly, this is where we're going to end up, and it's going to be fine. We're all going to be successful. We're going to move some properties around. We're going to interchange. There's going to be exits from certain states. There's going to be a mass entrance to others. That's the nature of business. The business hadn't changed that many colors since I've been in it. So be ready for a shift in education. Be ready for a shift in revenue. Let everybody know where you're going to end up.
Thank you, Gary. There are 2 eastern states that are seriously considering taking their QIP programs to 15, 20, 30% of the Medicaid dollars. And putting more dollars in is part of the deal. So these concepts that are coming out of the federal government are also going to get into the Medicaid side. Just expect all that. One last question, and then we're already over our time, so I apologize if there is one more question. I'm like an auctioneer, going once, going twice. Thank you all for being here, and Gary and Jess, thank you.